Hello, my name is Tahir Khalik, and I'm one of the Clinical Governance Fellows at the University Hospitals of Birmingham. And today I'll be talking about ankle sprains and about osteochondral injuries as well. We'll be going through the background information, clinical features, investigations, classification of ligamentous injuries associated with ankle sprains, and treatment. And for osteochondral injuries, we'll be talking specifically about background information, symptoms, investigations, and then treatment. Uh, Talking about ankle sprains, it is an injury to the ankle soft tissues. It is due to walking on uneven surfaces. It can also be because of falls, twisting injuries, or any sports injury. And a risk of sprain is greatest during activities involving side to side motion, for example, squash or tennis. The damage to the ligament, inversion is the most common, and that affects the anterior talofibular ligament, while eversion, as can be seen from the pictures, damages the medial and the deltoid ligament. The canonical features associated with ankle sprains are swelling, bruising, tenderness to touch, inability to weight bear, and instability of the ankle. The investigations or the management would always start with the history and examination. And then the first investigation you can do is a plain x-ray. And this can be in the AP view, the lateral view, or the Mortis views, which is basically 10 degrees of internal rotation. The Ottawa ankle rules are extremely important in the management of ankle sprains. It suggests that an ankle x-ray is only required when there is tenderness in the medial or lateral malleolar zone, inability to weight bear for 4 steps both immediately after injury, and an ED. And foot x-rays are required only when there is bony tenderness over the 5th metatarsal base or the navicular, because that's one of the other associated injuries which are very common with ankle sprains, and if the patient is unable to weight bear for 4 steps, again for both immediately after injury and an ED as well. If we were to classify ligamentous injuries, it can be graded into 1, 2, and 3. 1 would have mild damage to stretch to a ligament or ligaments, so there is no joint instability. Grade 2 is a partial ligamental tear, and grade 3 is a complete ligamental tear resulting in instability. The treatment is non-operative and operative. Non-operative is the mainstay of treatment, and you will see a lot of patients treated or managed in this way. Everyone knows about RICE, which is rest, icing, compression, and elevation, and that's to approach to a soft tissue injury. And you have to avoid harm: heat, alcohol, running, and massage. Simple analgesia such as paracetamol, NSAIDs, and cocodamol are essential. Immobilization in a walking boot, splint, and cast if the patient feels unstable on their feet and if it's really severe. Protective weight bearing such as crutches is essential for safety of the patient, and most importantly, physiotherapy. Operative management is only and only when non-operative management fails. Now, we'll talk about osteochondral injuries, and this is damage to the articular cartilage with or without underlying subchondral bone damage. It may be a result of traumatic incidents such as an ankle sprain, or with repeated microtrauma due to instability. The symptoms are very similar to ankle sprains, but along with that, there's a deep ongoing pain that cannot be healed or and is not improving. And as mentioned, chronic ankle pain, especially in children. The investigations are pretty much the same as an ankle sprain. So you start out with a history and an examination, and then you do an X-ray. However, because these are very hard to detect via X-rays, you would have to get a CT scan and an MRI scan as well. Treatment is very simple to ankle sprain. So you immobilize the joint and you consider non-weight bearing in an acute injury. However, if that fails, which most likely majority of these do fail, you would want to go for surgical management, which is arthroscopies with removal of loose fragments with debridement and marrow stimulation, and sometimes retrograde drilling with or without bone grafting can be beneficial as well for these patients. Thank you very much.